Hello, everyone. We'll be talking about diseases of the circulatory system today as it relates to ICD-10. A lot of things about the disease process that you need to know. So if you want to further your knowledge, make sure that you have your notebook ready so you can write down some of these maybe terms that you don't know, do a little Google search, or if you want to back up a guideline, okay? So there's a lot of guidelines surrounding the circulatory system because we're talking about the heart and the vascular system and
Question
the
already.
arterial system.
Will you need to be
Okay.
referencing the 3 manuals during this presentation?
Nope. Nah, don't need to. We'll have ICD-10. It's the only manual you're going to need. So the code range for ICD circulatory system is going to be I00 through I99. I think of the first character as I for ischemia, anything ischemic that has to do with the heart. Somebody else said that they always think of the I heart you know, and then so if it's an I, it means a heart. Oh. So whatever works for you. If it's a code that starts with an I, it's going to be part of the circulatory system. It's a disease of the circulatory system. And this is considered chapter 9, but you know, I say it again and again and again. Don't think of them as chapters, think of the first character, I's. This is going to be conditions and diseases of the circulatory system, but it's going to not include pregnancy, anything to do with childbirth or puerperium. And if there is a congenital anomaly of the heart, that's going to be someplace else. All right, we'll talk about that in another chapter because we have congenital diseases. Anything to do with baby or birth and babies, different area. And a lot of things can go wrong with the heart and the circulatory system with infants. So again, just keep that in mind, but you'll see a lot of excludes and includes and things within the guidelines that you'll be able to determine. Now, let's do a brief overview about the anatomy of the circulatory system. Of course, if we talk about arteries, that is the lumen, the tubular pathway of carrying oxygenated blood to the rest of the body from the heart. Okay, so the lungs oxygenate the blood, it goes through the heart, and then it is distributed out through the body, and the deoxygenated blood comes back to the lungs and the heart via veins, arteries, and then it'll go down to arterioles, and then it'll go down to capillaries, and that's where the exchange, the chemical exchange happens. And then it'll be from the capillaries, it'll go to the venules, and then it will go to the veins. Okay, and you want to make sure that you understand that arteries carry oxygenated blood, veins carry deoxygenated blood. Thus, in a diagram, they're usually drawn in as red for arteries, blue for veins, but in real life, it doesn't really work that way, of course. But if you do look at your wrist, so if you look at your wrist and you see the blue vessels, little purpley blue vessels that are closer to the surface, those actually are veins. And arteries, you know, they're the blood that comes out of your veins are a little bit of a different color than the blood that comes out of your arteries, and they will check for oxygenation in the blood sometimes, and they'll do a needle. Instead of doing a needle and catching the vein this way, they go straight down and tap the radial artery right here. So they insert that needle, they find your pulse, and then they insert that needle straight down and pull back. And when they get artery blood, then they'll send that off and do an oxygen study on that blood itself. It is a little bit different color, just a little bit, but the way blood works, it's somewhat of the same color when you look at it in the tube, but when it is exposed to oxygen, then it changes color. So it's a deep, deep purple color, kind of reddish purple color, and then it turns bright red when it is exposed to oxygen outside world. No, I don't know if you need to know that. You definitely don't need to know that for coding, but just a little bit of extra information. So for the circulation of the arterial vessels, then what you're going to look at wherever you see a vein and an artery, they're going to have common names. Okay, not always, but usually the arteries and the veins have kind of like sisters. So if you have a femoral artery, well, you also have a femoral vein, a large vessel. But let's look at some of these common names of arteries that you should probably be aware of. Now, you don't have to have all of these memorized. Just some of them, though, are access points to having procedures done on the heart and other parts of the body, and you need to be aware of them. Okay, let's start on the right side where it says left common carotid artery. And your carotid arteries, they definitely check those, and you'll see that in the documentation. If you have anything wrong with the carotid arteries, the main arteries that when people are running and they stop and they check their pulse like this, that's the carotid arteries. And so you get a lot of atherosclerotic disease in these arteries. You'll have blockages. So you'll see carotid arteries mentioned. Also, not only carotid arteries, but the subclavian arteries, which go under the clavicle, you'll hear those mentioned also as access points to get down into the heart. Axillary is under the armpit, because that's the axillary region. Notice that the brachial goes down the arm. That's, this part of your arm. So you got axillary under the armpit, then it goes down into brachial. Then you don't really talk about the other areas in the arms and the hands, except for maybe if they're going to do that tap into the radial artery for blood gases, then, otherwise, not so much. These other terms that you see are pointing to internal arteries. Of course, we have our aorta, and then they start dividing up the arteries via organ. So you have the splenic, the gastric, and then it just keeps moving on down where you'll have renal. When you let's see, let's not go down to the legs. Let's go look over at the other, the left side. You see the renal artery, you see the abdominal aorta. So the aorta comes up off the heart and then goes down the center of the body, kind of follows the spine, but it doesn't lay on the spine. And when that abdominal aorta, again, we're talking about the largest artery of the body is the aorta, and then it turns into the abdominal aorta, and then it bifurcates into two, which you get a right and a left common iliac artery, and then you see where that splits, and then those loops on the hips, that is where they're going to your kidneys are up high, but those that loop right there are iliac arteries. Then you go down to the femoral arteries down both legs. That at the groin is a very common access point to have procedures when they're going to go up and do procedures into the heart. The popliteal artery, you don't necessarily hear, unless they're having procedures done on the knee, you don't usually talk about the popliteal artery. But tibial and fibular, those arteries, well, actually, they just got tibial listed there, the tibial artery. And then we get down into the legs. So again, your arteries go all over. Wherever there's an artery, there's usually a vein it's got the similar name. Notice there up by the head, you have your cranial, the internal carotid, and then they start going up into the brain. Now let's look at the venous. Notice we have a left subclavian vein, just like we had before. We have a cardiac. We have a axillary, again, brachial. These are all veins. Splenic. Notice the names are very, very similar. But I want to bring to your attention down here the right saphenous vein. There is a right and left saphenous vein. Those veins in the lower leg are often used for bypass in the heart, the saphenous vein. So be very familiar with that, and any procedures that work with the saphenous vein being grafted for a bypass in the heart. Now let's go back up. You have the femoral veins as well as femoral arteries, but one of the things you may not realize, and this is something you need to do a little more research for yourself when you're doing procedures, but with whether they use a femoral vein or femoral artery to access the heart, that matters which side of the heart they're going to be working on, right? Because one goes into the one side of the heart and the other one goes into the other. That might be something for study that you need to go check. If they tap the femoral artery, then it's going to go into which side of the heart, the left or the right, and then same thing of a vein. Now, let's see. I think that's pretty much all I wanted to bring to your attention. Instead of talking about, carotid vessels, we've got jugular vessels, veins in the neck. The superior vena cava, that is kind of like the sister to the aorta. Okay, that's the vein, the major vein that's in the body, probably considered the largest vein. But you see how we need to have veins and arteries systemically through the body, and where you see one major vessel, there's going to be another major vessel, one vein and one artery, because we're returning the blood flow and letting the blood flow. It's a constant circle, and you really need to know some of the names of the major vessels that procedures are done on for coding. Now, for ICD, then we're predominantly talking about location of a disease or the disease process. So your larger vessels are going to have problems, as well as like I mentioned before, atherosclerotic heart disease, where you're going to start seeing those vessels that are tested, like the carotids and the subclavians. Other structures that you need to know for this body system or this area, of course, is our heart. That's our main pumping. That's the machine that does the work. The brain is what tells the heart to do its job, but the heart is actually the motor. And the heart has specific muscle. It's heart muscle. So when we get to musculoskeletal, we'll talk about the muscles a little bit and how they're different. The different actual tissue fibers are different. The heart is cardiac muscle, and it looks different from striated muscle or other types of muscle in the body. Again, it's a muscular organ. So any diseases that affect the muscles in the body can affect the heart, because the heart is actually a muscle. Something to keep in mind, right? So if a person has MS, then it's probably going to affect their heart as well, because their heart's what we think of it, the extremities, having trouble, but the heart's a muscle. And the heart, an interesting congenital defect is our organs are all laid out in a certain place in our body, of course, and they are also set up with laterality, right? We only have one heart, and you know how they say you put your hand over your heart. We know our heart, of course, everything you're seeing, everything in the camera is reversed for me, but your heart is off to the side of the sternum. I mean, the sternum is protecting it, but it lays off to the side a little bit. There is a disorder where everything is flipped in the body. So the apex of the heart leans out a certain way, and that's how you can tell if you're looking at the front or the anterior or the anterior part of the heart when you're looking at an image. But for people who have this disorder, it's actually flipped. So instead of the heart laying like this in the chest, it lays like this. Now, for the most part, you think, well, that's okay if everything is completely flipped. It's like a mirror image of itself. But that is a congenital defect. And whenever you have one congenital defect, an anomaly in the body usually indicates there's other things in the body that are a little off. And so they identify this pretty quickly after you're born. I can't remember what it's called though. I know we know somebody whose baby was recently born with that. The septum is the midline of the heart. So when you look at the anatomy of the heart, and it's kind of shaped like this, down in the middle of that is the septum. And we don't think too much about the septum, except for that it is, a strip of muscle that separates the chambers of the heart from left to right. But they can do a procedure. Let's say they go up through the femoral artery and they're going to work on one side of the heart to do an angiogram or whatever they're going to do. And they need to go into the other side of the heart. Instead of reintroducing another entry point into the femoral vein or going in through the neck or anything, what they do is they just puncture the septum. They just poke they just put a hole through the septum and look at the other side of the heart. And if you're coding in that as far as a procedure, you get to code that as two separate procedures. But they don't have to, take that one camera and strip out or whatever they're going to do. They just puncture through the septum. We have our left and right atrium, which is the top part of the heart, and we have our left and right ventricles, which is the lower chambers of the heart. I usually tell people to think of atrium, how you remember that's the top of the heart. You remember it because it's the attic. The attic atrium is the top, and the ventricles, think of the vestibule, which is usually you walk into the vestibule, which is usually the lower part of whatever building. Churches tend to have vestibules, they say, but they're on the ground level, and attics or atriums are up on top. The ventricles are the power of the heart. That's the squeeze, the ventricle squeeze. And the atrium is like an attic. It doesn't store it because it doesn't keep it in there, but it pushes the liquid or the blood through the heart, and then the ventricles push and it goes out throughout the body. Okay. Now, here's a quick view of the heart itself, and there's that aorta, the largest vessel of the body, whether it's a artery or a vein. And then here is the superior vena cava, and here's the inferior vena cava, which superior is above and inferior just means below. But this aorta curves and then goes down throughout the body, turns into the abdominal aorta, and then it bifurcates down there and goes out to the legs, and it has areas that go off to the arms, and then it has areas that go off to the kidneys, and we showed that a little bit ago. But you do need to have everything that you see here on this chart memorized. I don't tell you that you need to have something memorized unless you do, right? So I think you need to know the bones of the body, all the major bones of the body with their correct name. So it's not the skull, it's the cranium, things like that. But other things like the hip bones, it's the iliac crest at the top of the bones, not just the pelvis, it's the iliac crest, things like that. So that's the same thing with the heart. Everything that you see on this diagram for anytime you're dealing with coding or anatomy or anything in the medical field, every single term you see here needs to be memorized because you're going to use it so much. It's in diagnoses because it's the name, it's locational to identify the disease or the disease process. And we're not talking just about the chambers of the heart and the vessels, but also notice that we have the pericardium. That's the outside wall of the heart. And then we also have the myocardium, which is the muscle of the heart itself. So those are terms that you need to be aware of. Okay. All right. Now we're going to get into the diseases and the disease processes that are identified in ICD. When we start at the beginning, if you look at I00 through I02, these are going to be all rheumatic type conditions. So for acute rheumatic fever, okay, now that is a very specific diagnosis. You're going to just use the I00 through I02, and it just means acute. Now, can a person have results from rheumatic fever? Yes, they can have sequelas from rheumatic fever. That could be being sterile, being deaf, things like that. But that would be a sequela, a late effect of having a rheumatic fever. Make sure that when you look at the codes through I00 through I02, that they're going to want to know if the heart was involved, because rheumatic fever affects the heart. So I mentioned that it affects the reproductive system and it affects the ears, but that's because of really the fever itself. So a rheumatic fever can cause a high fever. High fevers will destroy the gonads, whether they're male or female gonads, and then will destroy the inner parts of the ear. But the next thing, whenever you see rheumatic fever, automatically think to yourself, is the heart damaged or been involved in the rheumatic fever? Because rheumatic fever is one that will damage the heart, whether it builds up scar tissue or not. Now, we talked about those codes, I00 through I02 being acute. You can also have chronic rheumatic heart disease. Now that's different than acute rheumatic fever, because you don't carry a fever all the time. So think of it in those terms. A sudden onset of rheumatic fever, but even if a person had an acute rheumatic fever, it could result in chronic rheumatic heart disease, or they could just have rheumatic heart disease due to other rheumatic conditions. The I05 through I09, that's going to be anything that's chronic rheumatic heart disease. And remember, I told you previously, we need to know if it affected the heart. If it affected the heart, then you're going to get an I05 through I09 code, probably in addition to, or it's going to come eventually with that. Pay very close attention to the difference between rheumatic heart disease and other types of heart disease. The key word, that magic word that you're wanting to see in the documentation to be able to use the I05 through I09 is going to be rheumatic. Right? And rheumatic is used for a lot of different other diseases. And if you ever have rheumatic as a term in anything else, it'll probably affect the heart in some way or another. So that's what you're just going to say. You're going to write rheumatic, and then I want you to write, not like an equal sign, maybe a colon that says, affects heart or heart, okay? Because rheumatic isn't automatically heart, but there is that association to it. Okay. Also, let me just go back real quick. When rheumatic disease happens in the heart, it likes to affect the valves of the heart. We have more than one valve, and you need to have those valves memorized, right? Because you're going to see them documented a lot with things like this. Next, we're going to do hypertensive diseases. There is a really large range of hypertensive diseases, but for the most part, the primary one that you're going to use the most is just plain old hypertension, I10, or we like to fondly say I10. This tends to be the first code that you memorize in I10, ICD-10, because it's in the name. And so many people suffer from hypertension. Now, if you open up your manuals and you look at I-10, you'll notice that in the parentheticals, there's other names: essential hypertension, malignant hypertension, benign hypertension. That all is I-10. But there's so many other different types of hypertension, and you'll see those in I-10 through I-16. You want to make sure that you pay attention to the details. So if it's basic hypertension or it's in that parenthetical, you're going to use I-10. But if you have hypertension associated to other diseases, that's when you're going to get into these other codes through I-16. So if a person has hypertensive heart disease, if they have hypertension and CKD, if they have any other type of heart problem, heart disease condition, it's going to, or they could have both CKD and CHF. Okay, and then that's going to have another code with the hypertension. And then on top of that, you're going to probably, you will be coding multiple codes, right? So a lot of guidelines, and they that surround I-10 through I-16. You will also want to pay attention to the includes, the excludes, and use additional code or code in addition, right? Code first, gonna see a lot of those. And this is what they like to test you on. Okay. Next, I-20 through I-25. These are ischemic heart diseases. And remember, I told you that's how I remember that it's that I's have to do with the heart, because it's ischemic. If you don't know what the word ischemic means, write that down and go look it up for the definition, because you're going to see it in documentation a lot. So whenever we have a problem with the heart that has something to do with the amount of blood that is getting into the heart, there's a constriction of some type, and these are for arterial blood vessels to the heart, then it's going to be an I-20 through I-25. What's the number one thing that you think of when you think of something happening to the heart? Most of you think of a heart attack, right? So if somebody says, like to a layperson that's not in the medical field, they say, what is something bad that could happen to the heart? And they would say, oh, we'll have a heart attack. That's right. That would be considered a myocardial infarction. And that means myocardial, the muscle of the heart, has been infarcted, which infarction means there's a blockage. There's an obstruction of some kind. This is different than heart failure. When we have a myocardial infarction, there's a blockage or something in one of the arteries of the heart that's not getting oxygenation, and it will die. The heart tissue dies. And if it dies, it cannot recover. Once it's dead, it's dead. Now, can other parts of the heart strengthen and take over? Absolutely it can. But that's why heart failure can be imminent after a myocardial infarction or an MI or a heart attack. Heart failure is different, a different diagnosis, in that the heart stops beating. Now, why would the heart stop beating? Well, there's several reasons why the heart could stop beating. But if it stops beating because of myocardial infarction, that means there was a blockage that the heart couldn't recover from. So there was no oxygen getting to the heart, and so the heart just shut down and resulted in heart failure. It stops beating. So an MI is a blockage of a vessel, a blood vessel, which would be an artery, and heart failure is the stopping of the movement of the heart. There's no pumping going on, right? Angina is just pain. The heart, there's pain in the chest that's caused by the heart, and usually it's because of a blockage, some type of obstruction of the blood getting to the parts of the heart, and it hurts. And thus they can give you nitroglycerin tablets, which is a dilator, and opens up the vessels and allows more blood to get through, thus it doesn't hurt. And then they mention here chronic ischemic heart disease. So this that is some type of a disease that has to do with a constriction of the arteries of the heart. And a lot of times this is like plaque buildup, right? Some type of heart disease. Think of that. There's some kind of obstruction. This is where when a person has angina and talks about having angina pain, this is where you'll see it. You'll see it in the jaw, particularly on one side of the jaw. You see it in the chest, and it radiates. It's usually on the left side, and it radiates down the left arm on the inside of the arm. Now, it could even hurt the pinky. We had a guy come into the ER one time that just had excruciating pain in his pinky. He couldn't stand it. He didn't know nothing happened. He didn't know what did it and everything, but he said it's the worst pain he's ever felt in his life in his pinky. Come to find out, he was having a heart attack. And then eventually it went up and the rest of the pain started. But that's what got him into the hospital. And in the back, right between the shoulder blades, pain right between the shoulder blades. Usually if it's angina, there's more than one type of angina, and some people pronounce it angina. Both angina or angina, either one is correct. It just kind of depends where it's like tomatoes and tomatoes, or route and root, it's wherever you're from. And there's different types, and you want to pay attention to that because that will be in the code description and be also in the documentation. Okay, we're going to move on to pulmonary heart disease and diseases of the pulmonary circulation. So this is the lung and the heart relationship. There's something messed up with that relationship between the lung and the hearts working together. I26 through I28 is that code range. These are going to be thus pulmonary embolism. A pulmonary embolism, pulmonary, just think lung when somebody says pulmonary. So we have a blood clot in the lung. Pulmonary diseases like COPD, or diseases of the lungs themselves that affect the heart. COPD is not an I code, though. Wait, no, it is. I don't know. Don't question me on that. My brain's not clicking enough to tell you what the COPD code is. But COPD is another one of those codes that you'll get memorized. Diseases of pulmonary vessels. So the vessels of the lungs. Okay. But notice this is other pulmonary diseases. COPD is a J code, not an I code. And we'll get to the J's later. Now we're in other forms of heart disease. Remember, other means that they don't fit in any of the categories that we've listed thus far. I30 through I52, this is a pretty big code range. Let's talk about these diseases that you're going to see. And if you don't know what some of them are, then you need to look them up and do some research. So pericarditis, remember that I told you that we need to know the names of the anatomy of the heart inside and out. So when we say peri, that means around. So the heart, the carditis or itis is inflammation. So around the heart itself is inflamed all around the heart. Endocarditis is the inside lining of the heart is inflamed and irritated. Non-rheumatic valve disorders. So we mentioned already the rheumatic fever, and rheumatic conditions affect the valves of the heart. Now this is, if it's not rheumatic and we have a valve condition, then where is it going to be located? In here, because it's non-rheumatic valve disorders. That tells you that so many valve disorders are due to some type of rheumatic condition that they have to have a whole list for non-rheumatic. Myocarditis is like pericarditis and endocarditis, except for it's the muscle of the heart itself that is inflamed. So you can have the outside lining of the heart irritated, you can have the inside lining of the heart, as well as the heart muscle itself irritated. Cardiomyopathy is the heart muscle is a condition that affects the heart muscle. Cardiac arrest means the heart has stopped. Okay, and then heart failure. The heart is cardiac arrest means the rhythm is stopped. The heart failure is the heart just shut down. The heart's not working. But cardiac arrest could, if somebody has a cardiac arrest, it can turn into a heart failure. Cerebral vascular diseases are going to be ones that affect around the brain. So cerebral, that's exactly what we're talking about. Your head is very, very vascular because the brain is what tells the rest of the body what to do. The heart may be the machine, but the heavy lifting, but the brain itself is just like a computer. The brain center of a computer, the same thing. Your brain is the brain center of the body. I60 through I69. So if anything goes wrong with the vascular system of the brain, okay, now we have to divide this up. Is it going to be traumatic or non-traumatic? So what that means is traumatic means we've been hit on the head, some outside force has traumatized the vascular system. Whereas if it's non-traumatic, something inside has gone wrong. So this is stated abnormal, non-traumatic condition. So it wasn't due to a blow to the head or something else that happened outside force, but it affects all of those cerebral arteries, the vascular system. Intracerebral hemorrhage. So maybe you had an embolism that ruptured a vessel and now you're bleeding inside. Mind you, not being hit in the head and causing a bruise or a contusion or a concussion. No, this is a bleed inside the head. And, your cranium is solid. And think of your brain as that bowl of Jell-O. Well, if you pour a liquid on top of the Jell-O in the bowl, where's it going to go? Right? It's going to have to spill over, and it can't do that if that bowl is closed off. And so you have a hemorrhage. Cerebral infarction is just like having a heart attack, but for your brain. So there's an occlusion, there's some type of an infarction, obstruction that is killing the tissue of the brain. And just like the heart, the brain, the little gray cells, they're literally called gray cells. Those little gray cells, once they die, that's done. You can't recoup that. Now, can other parts of the brain take over, just like the heart? Yes, it can. But the older you get, the harder it is for the brain to relearn how to compensate. Has a brain injury or brain trauma, whether traumatic or non-traumatic, the rest of the brain can compensate. But as you get older, the brain is kind of set in its ways and it doesn't want to relearn things. Can it? Yes, it can. It's harder to do. Whenever you have any type of an occlusion or stenosis, which is that hardening, you can have a pre-cerebral and cerebral arteries be affected. Pre-cerebral is like right before carotid arteries, before they go up. If you've got stenosis or some type of an occlusion here, then it's going to cause problems in the cerebral arteries. Continuing on with this, we can get even more specific. For a code range of I70 through I79, we have arteries, arterioles, and capillaries. Now, remember I told you that going away from the heart, the oxygenated blood, we have arteries, then it breaks down to smaller, the lumen, the little tube light gets smaller, and it's arterioles, and then it gets down to capillaries. Okay, so if there is anything that goes wrong with the arteries, arterioles, and the capillaries, then it's going to be I70 through I79. If we have anything in the same that affects the veins, and it would be veins, venules, and not capillaries, because capillaries are under the I70 through I79, but the veins, but included with the veins is the lymphatic vessels and lymph nodes. Now, lymph nodes also can have their own category, but they're not elsewhere classified. They can lump them into I80 through I89. Why why is the lymphatic system connected with the veins? Because the lymphatic system and the veins are next to each other, and they kind of have like this osmosis relationship. So things bleed out, not bleed like getting cut, but they leach, I think, through osmosis from veins into the lymphatic system. The lymphatic system is kind of the sewer pipe of the vascular system, right? So anything that waste or anything that needs to go through, run through is going to go out through the lymphatic system. We forget that there's not just red blood cells and white blood cells and platelets in our blood. It encompasses a whole lot of other different things. And all those other little different things is what goes through the lymphatic system. Okay. Other unspecified disorders of the circulatory system, meaning other things that aren't categorized, but there is a code for them. I-95 through I-99 is going to be your range. I see a question, but I'm going to save that until the end. Now let's get into the guidelines that we need to speak about, because there are a lot of guidelines in the circular vascular system. You're going to see these in any of the credentials that you sit for, any of the exams, because you don't want to make a mistake with these. And so they're going to test you. And why are there so many guidelines? Because there's so many things that can go wrong with the cerebral vascular system. If there wasn't, it's like I told you in another lecture, why do they have warning signs on things? Because people did it. Why do we have guidelines? Because they're applicable. We need specificity. We need to know what to do in a specific scenario. And so know that hypertension has a lot of guidelines, and it will be things like the causal relationship between hypertension and CKD. How do we code that? How do we code hypertension, CKD, and another ischemic type of heart disease? The different types of hypertension and what specifies them. Is it secondary hypertension or primary hypertension? Right? Those are things that you need to look into. So in the section of guidelines and ICD in the front of your manual, you need to pay attention to hypertension. You will be tested on every single one of these things that are on this list. Atherosclerotic coronary artery disease and angina. Now, this is ACD or CAD, excuse me. So coronary artery disease, because we have coronary artery disease, you're going to have chest pain. And they're going to ask you, is it with or without angina, right? And then what type of angina is it? Stuff like that. So there could be multiple codes that you need to be aware of. Now, you don't have to have this stuff memorized. You just need to be aware of it, because your manual will tell you what to do. You'll look it up in the index, and then you'll go to the tabular, and all these guidelines will be there in the tabular. Intraoperative and post-procedural cerebral vascular accidents. What we're saying there is that a cerebral vascular accident is a stroke. If a person has a stroke, did they have a stroke while they were on the operating table? Or during a procedure? Or did they have a stroke, after a procedure due to the procedure? Those TED hose that they put on people after they've had a procedure done? That's one of the reasons they're trying to prevent a stroke in people. Especially the longer a procedure that you have done, the longer you'll have those on. Sometimes you'll go and visit somebody in the hospital that's had a procedure done, and you may see them with those big, like not rubber, but inflatable devices wrapped around their leg, and you can hear it going pump, 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 pump. And what they're doing is they're literally massaging the lower extremities to keep the vascular system going smoothly. It's like giving you this little massage, because they don't want you to throw an embolism, a thrombosis, or something and have a stroke. Okay. Sequela of cerebral vascular disease, a late effect. Now, what are the late effects of having a stroke? Usually paralysis on one of the sides. That's probably your number one. And there is more guidelines that tell us what we do if, if it's the dominant side or the non-dominant side. What if it's not listed if it's the dominant or non-dominant side? Then how do you code it? Well, we default to right-hand dominance, right side dominance, because most people are right-handed, okay? And we need to know that as attributing to the late effect, especially if it has to do with some type of paralysis, okay? Pay a lot of attention to that. Again, you'll be tested on those details. And then acute myocardial infarction. So an acute MI versus there's a timeline, and it's so many weeks, okay? You need to know how many weeks distinguishes an acute MI from an old MI. You need to write that in your manual or highlight it in your manual and make yourself a note. Okay, so they'll say something like a patient returns to the ER with an MI. Patient had an MI 12 weeks ago. So is that an old MI? The previous one? Is it a subsequent MI? Is it, how are you going to code that? The guidelines tell you all around the definition of acute MIs in here, and you need to know the difference. How many weeks is it from the time that you have an MI to the point that it's no longer considered? It's considered an old MI. What differentiates an old MI to an acute MI, right? Because it's different codes. And this is pretty basic stuff that you have to have in your knowledge bank for MIs. Now let's look at how to code a code in this area. Postural hypotension. Do you even know what that is? Hypotension, not hypertension. Pay attention to the details. This is low blood pressure, and it has to do with your posture. So when a person stands up and they get lightheaded, it's because their blood pressure bottoms out, gets low. So what do we look? We look up hypotension in the index, and then we're going to see a whole lot of different types of hypotension. You're going to see hypertension and then hypotension. You want to make sure you got hypotension. Go to postural, because that's what this is. Now remember, hypertension is I10, but this is hypotension. And not only is it hypotension, it's postural. So it would be an I95.1. And then it tells you to go look it up in the tabular to confirm that there's not something else that you need to follow a guideline in. Now, Lisa says, should we code I11.0 and I150.21 if a patient has hypertension and acute systolic heart failure? What the guidelines tell you what to do. Now, this is a really, really good question to go ask in the club, because these two do happen together. I110 is not just plain old hypotension. That is hypertension that's associated with another disease. And I50 is the systolic heart failure. Let me give you a little heads up about dealing with different types of heart failure. You can have systolic heart failure. You can have diastolic heart failure. You can have systolic on diastolic heart failure. You can have both. So very seldom do you want to code heart failure as a 0.9 unspecified heart failure, because then it may be that way originally, but once the patient's being treated and everything, or especially when they're seen by a cardiologist, they are going to be given a higher specificity of diagnosis. So acute systolic heart failure tells you which chambers are being affected ultimately. And I have to look it up to see if that's the one that you code together, but it's probably true. That's probably those. I can't tell you off the top of my head without looking up, because believe it or not, I don't have all the ICD codes memorized. I like to think that I do, but that sounds accurate in my peripheral brain. My little gray cells are saying, yeah, I think that's right, but I can't tell you for sure if it is. Actually, if you go look up I50.21, it will tell you to code first the type of hypertension if it's included, and then it'll give you a code range to look at. And if you go to I1 1.0, it'll tell you to code in addition the type of heart failure, and it'll give you a code range to look at. So they reference each other. All right, great question, Lisa. Again, go to the club if you want more information about that, the cco.us/club. That's where all of our students put in their questions. And if you see anything additional, any great articles, that would be great to add there. We have another question coming in from Whitney. It says, can you talk a little bit more about the patient having elevated blood pressure reading without diagnosis of hypertension? Very good point. Yes, let's do that. How many times would a patient have to have elevated blood pressure readings before being diagnosed with hypertension? Okay, let's start with that. And then we'll do the first part of your question. How many times does a person have a diagnosis with elevated elevated blood pressure, which is not hypertension? Okay, separate. There is a code for elevated blood pressure, and there's a code for hypertension, I-10. They are not the same thing. It has to state that the person has hypertension for you to use I-10. If the patient has a elevated blood pressure, there is a code for that. There is also a code for white coat syndrome. And white coat syndrome is a diagnosis that when the patient comes in and is seeing the doctor, their blood pressure is elevated. But when they leave and they check their blood pressure at home, it's fine. Because they said when they see the doctor with the white coat on, it makes them panic, right? It's a real diagnosis. And so that is not an I-10. That's literally called white coat syndrome. Now, how many times? The answer is, are you ready for this? You don't know, because you're not a doctor and you don't get to determine that. There is no set number. A patient could come in 5 different times and get a diagnosis of elevated blood pressure and it still not be hypertension. He could come in 2 times and get a diagnosis of hypertension. Okay, and from elevated. He could come in 1 time and they say elevated blood pressure, and the next time they get a diagnosis of hypertension. All right, so we don't know. We can, if it states in the documentation elevated blood pressure, that is not hypertension. If it states hypertension, that is not elevated blood pressure, although technically that is the description of what, because it is a disease. Hypertension is a disease. Elevated blood pressure is a sign or symptom. Okay, but the first part of that question is patient having elevated blood pressure reading without a diagnosis of hypertension. So yes, okay, that's what I was meaning. 2 different diagnoses. You could see that on a test, very, very likely. All right, so pay attention to that. They're not trying to trick you. They're wanting to know, do you understand the disease process, and the verbiage? Okay, another thing that just makes the hair on the back of my neck crawl because it's not correct symbols is an up arrow with a BP. The doctor is trying to say the patient has elevated blood pressure, but up arrow is not medical it's not a medical symbol. And so you don't want to use that. And when you do that, you have to query the provider. So do you mean that the patient has hypertension, or do you mean that the patient has elevated blood pressure? Because that doesn't mean anything to me. That's not, you say it in a better way than that. I did not know that white coat syndrome had a code. Yes, it does. Go look it up. And then Pansy says, thank you. Oh, thank you. Well, I'm glad, Pansy, this is helpful. And again, this is one of my favorite areas. These are some of my favorite codes, the I codes, but they are extremely complicated because there are so many little guidelines around them. And the only way you get good at this is reading the tabular and paying attention to those guidelines and making yourself little notes. Make notes in the notebook, then go back, and when you got them all kind of shifted out and how you want them, then make them in your manual. But you will definitely, you'll definitely be tested on these. One more thing before I let you go. If you decide to get into cardiology as a specialty, again, they're just going to reiterate all of this, but you'll also want to know how the heart affects other body systems. Okay, but there are specialty credentials, and cardiology is one of the top 3 highest paid specialties out there. All right, that's it. Thanks, guys.